Hello, and thank you for joining us. The Southeast Mental Health Technology Transfer Center is pleased to present today's webinar event, Tools for Reducing Substance Use, Lessons from Integrated Dual Disorders Treatment, Part 5 of our Keeping It Practical series. Before beginning our presentation, I'd like to review information about our center and a few notes for today's event. Please note that the work of the Southeast MHTTC is supported by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. We use affirming, respectful, and recovery-oriented language in all of our activities. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs provides a unique lens through which we can address mental health priorities. We encourage you to visit our website to learn more. A few important notes to review for today's event. This event is being recorded and will be made available on our website for on-demand viewing soon. We encourage you to share your comments throughout the presentation using the chat feature. Please remember to select chat with all attendees if you would like to share your comments with all participants. We have allotted time at the end of this session for our presenter to answer questions. Please submit your question using the Q&A feature found at the bottom of your screen. And finally, for those who are interested, a certificate of attendance is available for download upon completion of our surveys. At this time, I would like to welcome Dr. Benjamin Druss, the Southeast Mental Health Technology Transfer Center Director, who will introduce today's presenter.
Thanks, Stephanie. So I am delighted to present to you Angela Rollins, PhD. She is a research scientist at the Regent Street Institute and associate research professor of psychology at Indiana University, Purdue University, Indianapolis. Dr. Rollins' research interests are primarily in studying methods for improving implementation of evidence-based mental health practices for people with severe mental illness. Recent topics include the measurement of program fidelity, improving clinical knowledge and skills, and reducing staff burnout. Clinical populations of interest include those experiencing homelessness, mental illness, and/or co-occurring substance use disorders, as well as populations that might best be served by mental health and substance use services integrated within primary care settings. Dr. Rollins has particular expertise in the implementation of assertive community treatment, illness management and recovery, supported employment, and integrated dual diagnosis treatment. With that, I will turn it over to you, Dr. Rollins.
Thank you, Dr. Russ. Welcome, everyone. I see people from all over chiming in. Welcome wherever you are in the country. I'm Angie Rollins, and as everyone said, we're going to talk about dual disorders treatment today, really focusing on the practical aspects of dual diagnosis treatment. So the general plan, pretty simple, it's an hour. We're going to talk a little bit about this whole notion of integrated treatment for substance use disorders. I'm hoping you take away at least 3 fundamental concepts. We're going to focus on 3 aspects that anyone can do with their clients who have dual disorders, and then a focus on what you can actually do tomorrow. Like when you wake up and you go to work tomorrow, what's something that you can do in your journey with your consumers? So that's very simple, straightforward goals that we have for our day. So before we kick things off, I know my friends at the MHTTC have some poll questions for us. I think they're coming. Oh, here they are. All right. So what level of familiarity do you have with integrated dual disorder treatment right now? So give us an answer. We'll give about, I think, 45 seconds for everyone to give their answer here, just to get the pulse on the group. All right. Answers are coming in. Looks like, okay, just a couple more seconds. All right, we've got a good chunk of people. It looks like we're around, a good portion of you have not heard of IDDT, or at least you're not very familiar. So that's great. I think you're in the right spot is basically what I'm saying, because I think we're going to start out pretty basic for today. So thank you for that. Thank you everyone for checking in. I really appreciate it. We're not seeing your slides. Uh-oh. Okay. Sorry, I must not have done that. Here we go. Sorry about that. Technical difficulties there. All right, so we're beyond the poll questions now. So in general, I know for some of you who have attended these webinar series, we're really focused on evidence-based practices and implementation. And even though we have these ideal models and they work in research, we find that in the real world, a lot of times it's difficult to translate these things. And I wanted to mention that even within implementation science, many of us are talking not so much about implementing things in the exact way that they were done in research studies in these very controlled environments, but thinking about adaptation, thinking about how you conduct your work in the everyday world with all of the pressures. How do we adapt things so that our consumers still get the function, even if it takes a slightly different form? And so our philosophy, I'd say a growing emphasis in my own work life is the perfect is the enemy of the good. And so we're just going to focus on what we can do in the near term to actually make things happen. And so I think Michelle Salyers, who's done a few of these and sort of orchestrated for a lot of us to come together, we're really our goals are really to sort of review some basic concepts, to present a few ideas, and then really to focus on the practical strategies for these practices. So the series, you might have gone to illness management and recovery. Then we had Emily Treichler give one on collaborative decision-making, and I hope you're hearing a theme across a lot of these interventions. Collaborative decision-making is sort of an underlying way of being with your clients that I think you're going to hear throughout. Leah Hicks gave a talk on housing and ACT for basic needs. And I think last week or the week before, Marina Kukla talked, and I think her colleague, Amy Strasburger, talked about lessons from supported employment. And then I'm talking about integrated dual disorders treatment today. And then Michelle is going to wrap up again roughly a week from now, to sort of wrapping it up and putting it all together. So that's where we are in the series. Hopefully you've been able to attend a few of these. So when we get to IDDT, integrated dual disorders treatment, what do we mean by that? And so I think hopefully most people know, I mean, we can mean a lot of things when we talk about dual disorders, but for this particular talk today, the two disorders we're talking about are mental illness and substance use, co-occurring in a single person struggling with these issues at the same time. And so why are we interested in dual disorders? So there's really two sides to the coin here. When we think about this, substance use disorders are common in the general population, even more so in people with mental illness. We'll have a couple of slides on that here in a second. And then mental illness is common in people with substance use disorders. So if you go to the SAMHSA website, so SAMHSA's brought us here today, they put out data every couple of, I think every year, every couple of years on some of these conditions. So if you go to this website, it looks like in the pre-pandemic world, I think these are 2019 data. If you look at anyone 12 and up in the US with any sort of substance use disorder in the past year using DSM-5 criteria, it's about 14.5%. And when we look just at alcohol use alone, a little over 10%. So very common in the general population. But look, when we get to people who suffer from mental illness, these rates go up even higher. And this is across a range of epidemiological surveys that have happened over time. Usually when you are looking at people with serious mental illness, and when I talk about serious mental illness, I'm talking about people with schizophrenia, spectrum disorders, bipolar disorders, severe mood disorders that are severe and long lasting over time, that when we look at that population over their lifetime, you can expect roughly about half. So depending on the study that we're looking at, roughly 40 to 60% might have had a lifetime substance use disorder. And then if we look at current substance use disorder, we're talking about 25 to 35%. So certainly higher than that 14.5% that we showed on the previous slide. So definitely it's a huge chunk of the population that we serve that are dealing with some of these conditions. So what do you think? This is a little intermittent audience participation. So you all, think about your clients who are, your consumers who are dealing with dual disorders, mental illness and substance use disorders. What outcomes are they really struggling with? What are you seeing in those consumers? If you want to type into the chat the sorts of things that you're struggling with your consumers. Let's see, homelessness. Oh yes, definitely. Thank you, Kelly. Anybody else? Yeah, employment problems, isolation, relationships, coping. Oh yes, support systems. Excellent. Yeah. Sound responses. Ooh, yes, definitely. Okay, so I think everybody's on the right trail here. So what does the research tell us? So people with dual disorders definitely struggle with a lot of the things that, and you guys, so I'm preaching to the choir here. I think you guys are recognizing all of the struggles that this particular section of our consumer population struggles with. So definitely more likely to relapse from their mental health condition, treatment problems, maybe increased hospitalization, certainly more, I think someone might have mentioned this, the whole issue of being exposed to violence or victimization, suicidal behavior, homelessness. I think that was the first thing someone brought up, incarceration or legal problems, medical problems. I'm not sure anybody brought that up, but certainly HIV and hepatitis, risk behaviors and infections in people with dual disorders. So the same sorts of things that we would see with anyone with substance use disorders, and certainly relationships problems, and sometimes increased service use like ER use. You know, these are folks that are getting injured or having issues and showing up in the ER. So I think everyone's on the right track there. But I don't want to leave you with the message just that there's this, where there is struggle, there's an opportunity. And I think there is hope. And that is the one thing I want to make sure that we emphasize, is that even though folks with dual disorders experience all of these issues that sort of they're compounding factors in their life and with their illnesses, that these dual disorders are treatable, that it is possible for people to get to a place where they attain some sort of stable remission from their substance use disorders. It does take some time, but it does happen. And that typically this recovery tends to happen it encompasses other areas of their life. So things like their overall health, their ability to work, housing, relationships, that all of those are sort of fundamental, and that recovery happens in those contexts. So I want to start you off with that. I do want to say a little bit of a disclaimer here. Now, when we talk about mental illness, we can be talking about all sorts of things here. So Typically, when we talk about dual disorders, it can be anything from this first category where we're talking about sort of milder mood or anxiety disorders, like not the serious mental illness, but sort of the, we used to use the term walking well. I'm not sure that that's the right term anymore, but certainly substance use disorder occurs at a high rate with those folks. Personality disorders, thinking about borderline personality disorder in particular, or antisocial personality disorders in the old language of the DSM-4, but certainly for those impulsive behaviors that come with that, substance use disorder is really common. But today's focus and the sorts of the model that I'm coming from, we're really talking about serious mental illness and co-occurring substance use disorder. So things like psychotic disorders, bipolar disorder, those things I mentioned today. So the things that we're going to talk about, I actually think they can be useful, even if you do treat folks that are maybe more in these top two categories. I think it'll be useful to you, but in terms of the whole evidence-based practice model I'm going to be talking about, it's mainly a model that's meant for these serious mental illnesses. So hopefully you keep that in context if you treat one of those other two sections up there, other two subgroups. So one way to really think about integrated dual disorders treatment is to have a contrast with traditional treatment approaches. And by traditional treatment approaches, I'm talking about either parallel treatment approaches where the mental health treatment is happening in this department by this group of people, and then the substance use people are over here, and they're not really interacting, but they're both treating the consumer at the same time, just sort of in parallel. And then there's also the sequential model where in a service system, someone will say, I need you to get clean, and then I'll treat you for your mental health condition. So it's sequential. Treat your substance use first, and then I'll help you with your mental illness. I guess it could be vice versa, but I think that traditionally what we see is people say, get clean, and then I'll help you with your mental health. And I always say there's lots, when I start to see a lot of rules about when people get access to services, that's when my alarm bells go off, where I start to think, is the system really serving the needs of the patient? I think that's typically when we see lots and lots of rules. I'm not saying there will be no rules, but when I see lots of rules around access, then I'm sort of thinking those are separate programs, and they're probably going to be less helpful to people that are suffering from mental health and substance use disorders. So the better way, and I've got a few research studies down here that you can go and look for if you're really interested in looking those up, reading about these different randomized controlled trials and other studies, is really integrated treatment. And that tends to be more effective than the traditional separate or parallel treatments in reducing substance use, and in some cases, actually producing positive outcomes in other areas of someone's life. Let's see here. Oh, goodness, that is so long. All right. So Mr. Williams, I'm going to go back and read that at some other point. That is a very long post. I'm sure I will look at it here shortly. Let's see. So integrated treatment. So what is it? So in the basics that I want to maybe start off with in terms of talking about integrated dual disorders treatment is just basically the opposite of what I described with the separate or parallel or sequential treatments. And that's that we want to really bring together the treatment of the substance use disorder and the severe mental illness, ideally the same program, treating the same person at the same time. There are different variations of that. Sometimes it's not always the exact same team. Maybe there is integration on other levels where there's coordination, at least, between the substance use provider and the mental health provider. But as much as possible, thinking about the treatment of of the whole person as a unique human being that brings these complicated challenges, that we're treating them at the same time. So that's the core idea of integration with dual disorders treatment. And then that second point there is really sort of an extension of that, and that we think about a multidisciplinary team and offering people an array of services that support their recovery in multiple life domains. So sort of what I was referring to you with the share a need work, that, you know, we have to get recovery in our housing, in our relationships, in our work life, in our personal life, and that really supports our recovery from substance use. And that's going to be a point I hit several times, and I think you'll guess what I really want you to take home with you today is that we actually sometimes that those are things that come before we're even ready to cut back on our substance use, is that we have to really get a range of services from a multidisciplinary team. And then that third aspect is that we really take a stage-wise approach. So that, you know, based on sort of the trans-theoretical model of change, we think about change, any difficult change that we human beings make. And if, for me, if it's, you know, cutting back on sugar and losing weight, you know, for our clients, it's substance use. For someone else, it's giving up cigarettes. That oftentimes very difficult changes happen in stages. They don't happen overnight. And so really trying to sort of step back and think about a stage-wise approach to recovery from both substance use and from your mental health condition and abstinence is really important. And so we have a very short presentation here today. I don't want to take too much time out, but you'll get the slides after this presentation, and certainly you can go back. There is a whole introductory video that talks, it has a couple of consumers talking about their experience of integrated dual disorders treatment and how it's different than other services that they may have gotten in the past. I really encourage you to look at that video, but certainly something you can do on your own that are out there on YouTube now. So, and a couple of other resources for you for later. Certainly this link to the SAMHSA store for all of the EDPs, you can actually get to several pieces of the IDDT toolkit. So many years ago, SAMHSA funded a whole bunch of studies where we put resources together to really help clinicians in the field implement some of these models. So there's real basic information about the model, and then there's a whole skills training manual, so like a treatment manual that you can go through in a small series of sessions with clinicians who might want to learn more about the practice, vignettes that really describe clients and really apply things. I really can't endorse enough that you go back and look through some of these offerings. The other thing I wanted to highlight is some of you might have seen the Ohio CCOE group from Case Western. They've been doing a lot of implementation around integrated dual disorders treatment. We call on them a lot in Indiana to come and train a lot of our folks as well. They have all sorts of great resources on their website, and they do lots of training and technical assistance. That's not really the point of today, but certainly if this piques your interest and you get support for it, that will be wonderful. That's a place that you can look for this particular practice. So then if we think about the full model, so this is, full fidelity integrated dual disorders treatment. These are the critical components that we typically talk about. So I'm going to go over 3 of these in more depth with you here momentarily. The 3 that we're going to go over are long-term perspective, stage-wise interventions, and I think access to comprehensive services. So we also want to mention assertive outreach. So thinking about the client populations that you mentioned, so some of the issues like incarceration, hospitalizations repeatedly, homelessness, that those are all difficulties that someone with dual disorders experiences. And so one of the things that we use to counteract the disconnect oftentimes when you're either frequently involved with law enforcement or homeless, is we use assertive outreach. So we don't wait for you to come to us. We take sort of a comprehensive, intensive approach, and we go out and offer services to you. Now, do we mandate services? No, and there's certainly a big debate about that, but certainly assertively offering at the very minimum the different types of services to those folks. And maybe if someone's not showing up for services, like trying to find that person and seeing if we can engage them in care. Motivational counseling, which I know that we've probably, it's been mentioned at least within the context of the illness management and recovery session that Michelle Salyers did. Motivational counseling is a tool that we often use, not just with people with dual disorders, but certainly anyone who needs to make a difficult change in their life. We use the Miller and Rolnick's model to really try to use a lot of empathy, roll with resistance, kind of work ambivalence in our favor. We really take a stage-wise, and what I mean by that is ambivalence. A lot of times people are not interested in cutting back on their use. And so we want to build ambivalence that maybe there's something wrong with their use. And then eventually, as we get further along, we want to have that ambivalence come down on the other side and towards where they're less ambivalent and they want to take an action step to cut back on their use. So using those motivational approaches, helping people to build their own reasons for wanting to cut back or quit their use or to work on their mental health recovery. Certainly over here on the left-hand side, thinking about substance abuse counseling being offered. And there's a lot more evidence, I think, these days. The evidence is built in terms of cognitive behavioral therapy being very effective in helping people to sort of link their emotional thoughts, their cognitions and emotions, and then their behavioral responsive drinking, and really seeing that link or using and trying to sort of interrupt that negative behavioral reaction or consequence to these thoughts is really helpful. Contingency management is another form of substance abuse counseling where we actually have some sort of reward for people when they have clean time and build that's something that has been really helpful. Hard to implement in the real world, but certainly something that that can be helpful, or just active substance abuse counseling in other ways. The one thing I want to mention about this particular component, though, is that when we are thinking about offering substance abuse counseling to people, we often don't offer it until people are really in an active stage of treatment. So that goes back to this one right here. So when people are in earlier stages of treatment, we might do a little bit more of this assertive outreach, the motivational counseling. We might provide them with access to the medications that they need for their mental health, or if they're willing to accept the medications for substance use disorder. So it's really, this block is really for people that have decided that they want to do something about their substance use, and they're really willing to take a few action steps for it. We also have found that when folks get access to social support interventions, family support interventions that really support their sobriety, that is really key in helping people to really get that a little bit of sobriety under their belt and to reinforce that with their family and their relationships. I mentioned access to medications. And I think that sounds simple, but I think what we see sometimes is we see some providers who are a little bit hesitant to give people psychiatric medicines if they're using. And certainly, you know, a psychiatrist is going to know if there is an actual contraindication. But we always say, you know, providing access to their most of their psychiatric medications. We don't want to require that people have that they're completely clean from substances before they get treated for their mental illness. It doesn't mean that you might have to make different choices about the meds you select, certainly. We're going to talk a little bit more about taking the long-term perspective here in a minute. I've mentioned this maybe a couple of times already, and we'll talk a little bit more about it, but that access to comprehensive services, employment being a big one. These, I think for a lot of our consumers with dual disorders, that they really want to get back to work. They want to have an income. And so thinking about how we offer those services is really important. Harm reduction. So harm reduction is a whole set of approaches. It's a mindset, I think, that we have with clients with dual disorders or any kind of substance use disorder, where we really think about trying as much as possible to promote the positive health outcomes and promoting healthy outcomes. So it could be anything from actually accepting reductions in substance use as opposed to complete abstinence. Certainly abstinence is the goal, and that's for people with serious mental illness. Abstinence is the most healthy way to recover from a serious mental illness. But how do we get to abstinence? We'll take reductions in use along the way and slowly get there. You know, maybe staying clean over the weekend is very difficult, but you know, staying clean on a Tuesday is a place to start for some folks. And also, you know, harm reduction, we also think about how we offer people maybe clean needles if they're using, if they have injection drug use, so they don't get HIV or hepatitis. I work with a doc who does infective endocarditis, all of these negative outcomes that can happen when people abuse substances. Certainly, there are many other ranges of things that we offer in terms of harm reduction. Access to secondary interventions for non-responders. So the full package of what we give people, oftentimes that helps a lot of people over time, over a long perspective, but then we really want you to track in the whole evidence-based practice, you know, sort of track people that are getting stuck at certain stages and not making progress. And then we might amp things up and offer them other interventions. That might be someone that you offer a residential treatment offering. You might offer them medications for substance use disorder to really help them get some clean time. And then, of course, I think access to peer support. That's something that we're just learning over and over again is so incredibly helpful to people with, you know, with all sorts of mental health conditions and substance use disorders, but certainly people that have dealt with dual disorders, being able to talk about their recovery journey and give people hope that that can be something that can happen for them is really, really critical. So this is the big shebang in terms of what we think about with the whole IDDT model. So it's a lot, right? I mean, it's a lot to keep in mind. So what are the things that we could focus on if we only have a little bit of time? And so I picked out the three. I couldn't narrow, it was difficult to narrow it down to just one. So let's start with three. So that's, the first one is the stage-wise intervention. So that's really about, you know, that you are going after treatments, that you're putting on the treatment plans, things that matches the consumer's stage of change, and that stage of change drives the treatment plan. We'll talk a little bit more in depth about what that looks like. Taking the long-term approach, and I always say, like, this really is, you know, deep breaths, everybody, patience, because this might take a while. This is not going to be an overnight sort of thing. And I think, you know, Dr. Dress mentioned I do burnout research, and I think sometimes we get burned out because we get way ahead of our clients and we get so frustrated. And so taking that long-term approach in terms of years, not even months or weeks, but years, to sort of really get a handle on some of these challenging issues is what we should be thinking about. And then the final one is providing and encouraging a wide range of services to help people in their recovery from both their mental health condition and their substance use disorder. And so I always think about this: treatment gets you to wellness. So don't require wellness in order to get into treatment. I have a couple of stories to that effect when we get to that. So we'll talk about all three of these here in the next 20 minutes or so. So the first one, assessing stages of change in treatment. So one of the things that I recommend here, so I've got another couple of links for you, is really to look at how you're going to stage some of your clients. These are all tools that are, you can go to this website and get the tool. I think it's an 8-point scale, and it really defines like where someone is in their stages of substance abuse treatment, from being on the lower end of being sort of pre-contemplative, contemplative, all the way up to being in an active stage of change, and then being in a relapse prevention and recovery mode. So there are links and how to get to that, and a couple of nice videos to sort of talk about how to do that assessment. So assessing their stage of change. So just having an awareness of where that person is. So hopefully this is not the first time you've seen some of these elements. So that the substance abuse treatment scale is really, I think it's 8 or 9 anchors on this, but I just want you to think in terms of 4 broad categories. So a lot of times when people first come to us, they are in this top group here, where their stage of change in their, their sort of intrapersonal stage of change, what's happening inside their head is the stage of change. The stage of treatment I always think about is the external observed lived experience, what we're seeing on the outside behaviorally in the person in terms of their engagement in treatment. And then what this looks like is over here on the right-hand side. So in this first block, the engagement stage of treatment, we're really talking about people that maybe have either no contact with you in your service that you're offering, or a regular contact. They come in when someone pushes them, their wife or their spouse or their mother pushes them to go into treatment. They make an appointment, maybe they show up once, but they don't come back again. This is someone that maybe in terms of substance use, they don't really consider their substance use or their mental illness a problem at all. So I always say they have no ambivalence at all. They have no ambivalence because there's not a problem at all. And so these are often people that you don't see a whole lot, if you see them at all. I'd say when someone is first starting to come into treatment, and they're actually coming on at least a semi-regular basis, this is more like the persuasion stage. So this is someone who's in contemplation or a preparation stage. They're having regular contact with you. They maybe still don't view substance use as the core root, or their mental health condition is the core root of their problems, but they certainly can recognize that something is going wrong in their life. I always say, this might be someone who says, my mother's nagging me all the time, or my wife is nagging me all the time, so I guess I need to do something about it just to shut this person up, So that might be the only reason they're coming to you. So that is someone who's in the persuasion stage. And we'll talk about what you do with each of these in a second. But your first step is just to try to figure out roughly in these 4 stages where they are. This action stage, I think a lot of our mental health system is set up for the active treatment stage, where someone's coming in regularly, they have a relationship with you, they really recognize that there is something wrong with their substance use or their mental illness, that it's interfering with their personal goals, and they're ready to start working on getting some skills or supports. They may even be talking about cutting back or quitting, and they're really seeking out ways to do that. And then in the final stage here, it might be someone who has attained some clean time, at least 6 months or more. And this person is really, ready to take things on. They really want to keep this achievement of maybe having 6 months or more clean time. They want to find ways to really keep it that way. They want to move on with their life. They might have other recovery goals that they're ready to tackle. And so that's just a fantastic, this is our bread and butter, right? We're always looking to get here to the relapse prevention stage. So just a way to sort of be cognizant of where it is that the consumer that you're dealing with is, where they're coming from. I find that a lot of people love to use the term pre-contemplation. And I always say, just be cautious with that term, because that's someone that's probably not seeing you very much at all. So if you're seeing someone regularly, have a little bit of hope, because there might be room for you to perform some persuasion. You might do some motivational interview. So that's what we'll talk about next here. What do you do with these stages? So for someone in this first stage, now think back to the model, those model elements that I talked about. What are some of the things that we can help people with? So when someone's in that really early engagement stage, let's say they're coming in irregularly, but they're at least enrolled in your service. So we might be doing some outreach for them. If it's someone who's homeless and needs housing, we're going to do everything we can to help them to get housing. We're going to provide them with that practical help that they need. Maybe they don't have health insurance at all. They're not on Medicaid. And maybe that's something that we need to do. Maybe this is someone, because they're not in recovery at all, maybe they need more crisis intervention, treatment planning. You're really going to try to develop a rapport with them so that they keep coming back to you. In the contemplation and preparation or persuasion stage, you're going to do a little bit more education. You're going to talk to them a lot about their goals, maybe do some motivational interviewing around those goals. You'll reach out to the family to support them, maybe offer a little bit of peer support to someone who's considering that substance use and mental health recovery is something that they need. And then active treatment is when we do all-out substance abuse counseling. Maybe we give them medication for their substance use disorder, skills training. They might get enrolled in some self-help groups. And then people that are in the relapse prevention stage, we're going to do a lot more relapse prevention planning with them. We're going to do some skills training, help them to maintain that sobriety that they've been able to achieve, get them some self-help, and then expand recovery in other areas of their life. So we sort of tailor the kinds of interventions that we do to where the person is. And the big thing is that we want to be cautious about really, encouraging them to go into substance abuse counseling that's really active treatment oriented, when really in their mind, they're still up here in persuasion and trying to figure out if substance use is even a big deal to them. And so matching up that stage is important. Oh, and Teresa, you'll get the slides after the recording. I know that the SAMHSA folks have let me know that. So thinking about the course of dual disorders, I always say recovery is definitely possible, but we really think about both substance use and severe mental illness as conditions that we don't necessarily cure, but we certainly can get recovery. It's just going to wax and wane a lot of times. A long-term, time unlimited focus is really important. Now, this is a really busy slide here. It'll wake you up if you were getting a little sleepy, but basically what it's showing here is that in one of these studies, this is the New Hampshire dual diagnosis study. It's an older one, but I think these concepts are still true. When people first enter treatment, so think about this. These are the people that are not even ready for substance abuse counseling, this from red up to yellow. So over 90% of people, they're not even ready to go to your substance abuse group, right? Like when they first come in. And then looking at this group from the red up to the yellow, we only get people, if we look at the people that are in the active stages of change, look at this group grow. It certainly grows over time, but it grows to the point where it is just over half of them at the 3-year mark are ready for the active treatment groups. And I want you to sit with that just for a second, that it could take you, with your average client, it could take you 3 years just to get half of your dual disorders caseload, providing great services, 3 years to get to a point where roughly I think it's a little over half, close to 60%, are ready for groups focused on substance use, active treatment groups. And I just think that that is extremely important for you to understand that this, it could take a while before they even want your traditional groups. So maybe thinking about groups and counseling that is geared towards these earlier stages of change is extremely important. All right, so I'm going to go through here. How do people obtain remission? So certainly thinking about comprehensive services, wanting people to have, this is a great these are social anthropologists did this study, and I think this holds true even now, that really when people obtained remission, they obtained it by getting stable housing, having a sober support network, sometimes a family, sometimes not the family, some other form of sober support network, regular meaningful activity, and for a lot of people, it's work. Work helps them to get to recovery, and trusting clinical relationships, that those were 4 big ingredients that people needed in order to have that recovery. And so the implication is that abstinence comes after these sorts of supports for someone in their general life are in place, and that relapse comes after the loss of supports. So we really need to focus, I think I needed to stay back there, like really making sure that we aren't demanding that before you get into my employment program, I need to see some clean time, that's actually the opposite of what it needs to be. Now, do I as a supported employment specialist take someone to a job interview when they're intoxicated? No. You say, well, we'll go back and do it tomorrow. Let's try it again tomorrow. But certainly engaging people around their goals, helping them to really have, attaining their recovery goals, getting back into the workforce is really an important element of getting to sobriety. And we find that a lot of people want to put a lot of rules around that, where they'll say, I need you to be in recovery before I'll let you into my recovery program. I have some old war stories in my VA time about some nonsense like that, but I think it happens in a lot of different places. So I know I need to move here. So if you only do one thing differently, I would say maybe it's 2 things here, but to really think about the stages of change, making sure that you are lining up the kinds of interventions that you're offering people, that they line up with their stage of change, and that you're not getting too far out ahead of them. And that I like to engage consumers with me on that. Like, this is not something that I assess and hold secretly on my clipboard, that I, put up the stages of treatment scale right on, show them those stages and ask them to reflect. Where do you think you are on this stage? Where are you at? And what do you think we should offer you? And just make it something that you discuss with the client themselves. So thinking about your clients in a stage-wise perspective is extremely important. And I know I am getting to the end of my time. Wait, I feel like, I know we might have a few questions. Maybe since we are at 12:48, why don't, I know I've talked about a lot of different things. If you have a question, you could certainly put that into the chat. But also, if there's something that's hit you so far in what I've talked about today, that you think you could apply, you could wake up tomorrow's Friday, you could wake up Friday, and your clients with dual disorders, is there something you think you could put into practice with them? And if you could provide that in the chat, that would be fantastic. And I know we might need a little bit more time for questions, but certainly if you had other questions, I'll be watching the chat for questions as well. All right. Not everybody is ready for active treatment. That is a big take-home message. And when I put on my burnout brain, I will say, If everyone's burned out, sometimes with this population, it's because you're working towards a goal that the client is not ready for. Yeah, educate clients on stages of change to build rapport. Yeah, I say don't do this on your own. Enlist the client in helping you. Not ready for treatment is calming. Yeah, absolutely. Sharing with your coworkers. Fantastic. Feel free to put, if you have a question that you had that we didn't, a burning question, feel free to put those in here. That is quite the goal, to improve collaboration between fields and systems. That's a big ask. But certainly getting started and starting that conversation, like, let's work together. Let's think about, I talk about anything, any of implementation of almost any practice. I like to think about what, as the consumer, pretend that I'm the consumer and I walk in the door, whatever that means in today's world, walking in the door virtually. But what do I see or feel? How am I treated? And that's a good way to sort of think about what we're offering to people. Knowledge to my peers are focusing on, yes, fantastic, yeah. And motivational interviewing, that's a whole, we could spend 2 whole days on motivational interviewing and how to do that, right? So that's a tough one, but certainly trying as much as possible to really understand and match up what it is that the client really wants out of life, their life recovery goals, and how their substance use or their mental health condition is getting in the way. That's the crux of it, right? Fantastic. All right. Any other lingering take-home messages or questions? Oh, Miller and Rolnick. Except I want to make sure this is to everyone. Here, I'll put Miller and Rolnick. They've written books. Oops, except I'm spelling it wrong. So it's there in the chat. Sorry, I should have put a couple of those books up there. Let's see. There's also, if you're interested in motivational interviewing, I think the website used to be motivationalinterview.org. I'll write that in the chat too. I think that's what it was. And that's got all, I mean, if you're willing to read, it's got all sorts of things. And I believe that's all in the public domain. There's all sorts of worksheets, exercises you can do with your consumers. I always think about motivational interviewing. There's the grand principles like rolling resistance, developing empathy, helping people to feel confident in their ability to change, those sorts of things. And then there's the micro techniques, and then there's exercises that really embody all of it. And so that website is a great one if you want to look a little bit more at motivational interviewing. So it's a lot. So it's not something that we could probably introduce it in a 1 hour webinar, but really practicing it is key. Oh, absolutely. Absolutely. Yeah, that recovery is often just like some of the self-help and 12-step models say, that really, 1 step at a time, it's gradually. I think that those are really important. Yeah, great start to bigger learning. Fantastic. Great. All right. Well, are we ready for the final poll? The ending poll question. I realized I didn't share results the first time around. Sorry about that. I'm not great with
All
these.
right. Thank you so much, Dr. Rollins. We appreciate your presentation today. Yes, we will go ahead and launch the ending poll here for everyone to take part in, and give folks a chance to do that. And again, we still have a few more minutes for folks to enter in a question or a concern or a thought in the chat as we wait for the last final few minutes here. But while we do that, Dr. Rollins, do you just have some final thoughts on your presentation or something that you want to end on a positive note for today's presentation?
I would say that I approach implementing anything new the same way I talked about recovery from substance use and mental health conditions, that it's stage-wise, it's long-term, you're gonna have successes and setbacks, that you give yourself some grace and you keep reminding yourself of the end goal and what you want to get out of learning something new. And so that, you know, the whole object of this series is that no one is perfect. We oftentimes don't have the resources to do the, you know, all of those dozen components that I put up there, but just focusing on the things that you can do and take a stage-wise approach to intervention, you know, yourself and making changes in your own work life. So I would say give yourself the same grace that you give your clients, and that we all make progress that way. All right, so should I share the first results here? How confident are you that you can help your clients learn? It looks like we got about half. Oh, poll ended. So I'm going to share results for that
sure,
one.
if you want to put that up.
Okay. Did it come up?
Yes, I see.
Okay. Okay. So pretty good. Some confidence there. That's great. All right. Great confidence. All right. So then in the next poll question, oh, did I already do, is that the second one? 2 questions.
I do think we have to move on to our evaluation questions.
Sorry.
Thank you so much. Yes, we definitely appreciate your time today in presenting on this topic. And just a reminder for all our attendees, we will send out an email containing the links to access the on-demand recording and the slides. So you'll definitely receive an email with that information in it. So the Southeast MHTTC thanks you for your participation in today's webinar. We value your feedback and invite you to evaluate this event. Please complete a brief SAMHSA required survey by visiting the link presented on your screen. Completion of this survey will provide information to SAMHSA and assist us in planning future events. Afterwards, you will be automatically redirected to additional questions from the Southeast MHTTC regarding the impact of this event on your knowledge and skills. There, you will have the opportunity to download a certificate of attendance for your records. Please allow 5 to 10 seconds for your browser to redirect you. Again, our center appreciates your participation and feedback. We hope you will join us for future events. Please visit our website to learn more. This concludes today's presentation.